excited to be here. Just I'll let you have these out. Goodbye. I'm a pretty informal speaker, so I like this to be very informative. If we don't want to go off the slides, we can talk about anything you want to talk about. I can almost talk about pretty much a lot of things in healthcare because I've been in healthcare for going on 40 years now. As Justin said, I got my first degree at Rick's College, and I had two goals in life, to tell you what a poor goal setter I am. One was to never, never, never go back to school. Didn't accomplish that. And the second one was to get out of Idaho, because I was born and raised in Idaho, and I haven't accomplished that one either, right? We had somebody here my last semester, and we've never left. So, but I am very pleased to be here. And healthcare is something that I love to talk about, and I love especially to talk about to people who are going into healthcare. Because one of the most important things to me is that you know what you're getting into. Because I will tell you that it can be the most rewarding career you could ever have, because you're dealing with people's lives. You are going to make a difference in people's lives. Even though you may not be on the front lines of their care, you will have the keys to make a lot of decisions about what happens in their health care. And so you will touch a lot of people's lives. And so it is the most rewarding career. However, with all that said, it is the hardest career path you could ever choose. Because I think it's physically demanding, it's emotionally demanding, it's mentally demanding, in a lot of ways it's even, in my mind, spiritually demanding. And so one of the most important things as we talk about this, and I'll talk a little bit about the characteristics for healthcare leaders for today and tomorrow, but one of the things that I always tell students when I talk to them, the most important person in your career is you. So the best thing you can do is take care of yourself so that you can be successful in your career. So I always promote that as I talk. What I kind of thought I would cover a little bit about today is I wanted to talk about healthcare leadership. Because to me, even I started let me tell you a little bit about my career path. When I first graduated from nursing, I went to a very small hospital in St. Anthony, Idaho. Does everybody know where St. Anthony, Idaho is? There's not a hospital there anymore. But it was pretty small. There was like 10 beds, but you did everything. We delivered babies, we took care of the ER, we had to do everything. So it wasn't a very big hospital. And I was there for about 6 months, but we really lived in Ashton, Idaho. Do you know where Ashton, Idaho was? Some of you do. And they had a hospital, which they don't have anymore. I don't know if that's a good sign or not. But, and again, had a very small hospital where we did everything. Then I spent about a year there and I came here to Madison Memorial, which is the hospital here in Rexford. And it's grown tremendously. I spent 24 years and 11 months at Madison Memorial Hospital and loved every moment of it. And I actually started out as a staff nurse, and I worked my way into the as a staff nurse, I worked in 3 or 4 areas, and I went as a house supervisor, which is kind of a mid-level leadership, and I went from house supervisor to the director of nurses. There was starting to be a lot of change there. We were growing. We had built the new hospital, not the brand new one that's there today, but the one that was kind of there previously, which has changed significantly. We had been through a nursing shortage, and I had worked about 17 weeks with not one single day off. And that's a long time, let me tell you. And I got kind of burned out. So I decided I needed to change. And so I had a friend of mine who worked in education who said, Kathleen, she called me up one day and she said, you need to go apply for this position because I've already sent your reference letter in. She knew it was perfect. So I went down to Eastern Idaho Technical College and applied to be the chair of healthcare professions and was fortunate to get it. And let me tell you, that was a dream job. I had to be to work somewhere between 8:30 and 9 in the morning. I was usually done somewhere between 2:30 and 3 in the afternoon. This is my husband, by the way. He works here before me. And I had, on Fridays, I tried to leave at noon. I never worked a weekend. You had no responsibilities on the weekend. I had 3 weeks at Christmas off. I had a weekend for spring break off, and I had 2 months in the summer. And so to me, I had the perfect job. So why did I jump from that job to this job? You know, sometimes I probably question it myself. But I was there for 10 years, and one of the things that I had the opportunity to do while I was there was be on the board for Eastern Idaho Regional Medical Center. And their CNO left. And the CEO at the time, who is Doug Crabtree, which I know many of you have visited with, pulled me aside after a board meeting and he said, Kathleen, I've got a couple applications for this position. I wondered if you'd take them and look at them and tell me what you think, see if you happen to know that. So I said, sure, I want to be a good board member, do what I needed to do. So I took the applications, I took them home, I read them through, I read their resumes, I wrote down my questions and what I thought were pros and cons to look at. And I called up Doug and I said, I've done this, when would you like to meet? He says, well, how about at this time? So I went over to his office and met with him, and I sat him down and started talking. He put him aside and he said, no, I really don't want to talk about these, I want to talk about you. I want you to apply for the position. I had never dreamed I'd go back into acute care. I was really fortunate and did get the opportunity to apply and get the position after a day's worth of interviews, and I'm thrilled to be back in acute care. But my life has changed from that schedule to being at work somewhere between 6 and 7 in the morning, and I do try to be home between 8 and 9 o'clock at night, and I do work 5 days a week and sometimes 6 and 7 days a week, depending on whether or not I'm on call. But it is so exciting, and I've been there for 5 years. And when I first went to IRMAC 5 years ago, things hadn't changed in my mind that much from when I had been in an acute care hospital 10 years previously. But I can tell you from the time I've been at IRMAC 5 years ago to now, just in 5 years, the changes are astronomical. And I think they're going to get even greater. And that's kind of what I want to talk a little bit about today. So what I thought I'd talk about is, and I think these are kind of hot topics for healthcare. Why and what needs changed? I mean, if it's changed that drastically in 5 years, why? And what really needs to be changed in healthcare? How does healthcare reform affect the healthcare environment? We hear a lot of things about Obamacare, Affordable Care Act, which, by the way, what is the difference between them? Who said it? They're the same. They're exactly the same. They are. It's just two different terms, and some people don't know which one you're talking about. And then what does it take to be a leader in today's and tomorrow's healthcare? Because I think it does. Like I said earlier, can be the most rewarding career, but it can also be the most exhausting career if you don't know what you're getting into. So that's one of the things I like to do. So why does healthcare need to change? First of all, it's pretty expensive. People really don't like to come to the hospitals and have to pay $10 plus for a Tylenol, one single Tylenol, that we buy a whole bottle for of $250 for 47 cents. Why has healthcare got expensive? By the way, I'm an interactive speaker, so you don't get to sit there, you have to talk to me. Why is healthcare expensive?
Well, with your Tylenol example, there's a lot of labor that would go into that.
Okay.
Because it would have to be prescribed, and then the people in the prescription card would have to pick it up and read it and push it out, and then have to go back there.
You're absolutely right. But really, that great? I mean, a Tylenol really costs less than a penny. So why do we charge? And actually, I got a complaint from a patient just 2 days ago that was really frustrated because when she got her bill, it was $74 for 2 Tylenol. No, that's accurate. That was her complaint.
I think it dates back to the 70s when doctors started charging insurance companies instead of actual patients, where insurance companies, they don't really audit a lot what would go on, so doctors can kind of charge possibly more for less, and then the pharmacy companies kind of just a monopoly that they're starting to kind of grow, and if a doctor can do 10 tests and the insurance company will pay for it, then they'll kind of do 10 tests to be safe, and then the patient will have to pay for it, and it's kind of just grown from since then.
You're absolutely right, and some of what you said too. And a lot of doctors did that. They ran a lot of tests that they didn't need to. Sometimes not necessarily for the money, but because there was a time back in the 70s, 80s when there was lots and lots of health lawsuits. People had something that didn't have the outcome they wanted, and they immediately contacted a lawyer. And there was a lot of lawyers that didn't have enough work, and they seemed to love healthcare suits because you could sue for a lot of money, which meant a lot of money to them. And so a lot of doctors, we used to call it, excuse my language, but CYA. They used to cover their, because and they did a lot of testing and things like that for that very purpose. They didn't want anything to fall through the cracks. I told you I've been in healthcare for 40 years. I really do remember when you used to come to the emergency room with an arm that you fell on, the doctor would really examine it, and if he didn't think it was broke, then he would put you in a splint and say, now if it's not better in a couple days, come back, because he didn't want to have to charge you an x-ray. You come into the ER today, if you fell on your arm, whether you have bruising, swelling, anything, you're gonna get an x-ray if you told us you fell on your arm. And the reason for that is because doctors are expected to not have anything fall through the cracks and for fear of that liability. The other reason it's very expensive is healthcare, unlike most businesses. And that's one thing that people don't get. Healthcare is a business, you know, and we have to survive just like any other business. But we have some things thrust upon us that we don't have choices about. Number one, we can't choose who comes in to have care. We have to take everybody, regardless of their ability to pay. So the biggest reason healthcare costs have gone up so much has a lot to do with underinsured or uninsured. Meaning that if someone comes into our hospital, has a trauma, which is not uncommon here, but they have no insurance, we still have to care for them. Now their medical bills may amount up to over $100,000. Can we just continue to write that off and still stay in business? We can't. So the only way we can do that is then we have to charge someone who can afford to pay for it more than it really needs to cost to compensate for the person who cannot pay for their health care. Because there's no free lunches out there, so to speak. Someone's got to pay.
Would a sliding scale in that case be a partial solution to some of those problems?
And we've tried really hard to do some of those things. We really have. And if you look at it, that's kind of a little bit about what health reform is doing with their insurance exchanges. It's based on your ability to pay what insurance exchange you can get. And at the same time, insurance companies decided that healthcare is big business. And even today, I think the last report I read, insurance companies last year grossed over $387 billion. That's a gross. So that means that's not what they paid out for claims. That's their revenue. That was their, not gross, it's what they, what's the word I'm looking for? That's what they made last year.
Their net operating.
Their net, yeah. And so it is very expensive, and we got to figure out because it's not fair to everybody. The second one, even though we have one of the most expensive healthcare systems, it's very hard to navigate. You guys are pretty young and healthy and may have not experienced this, but do any of you go to one single doctor for every single one of your healthcare needs? How many of you have experienced where you have to go to one doctor for one thing and another doctor for another? For instance, you know, for my age, I go see an OB/GYN doctor for my primary health care, because being a female and being in that, but I also have high cholesterol. Well, she doesn't want to deal with that, so then I have to go see an internal medicine doctor for my high cholesterol in order to cover that. And it's fragmented. They don't talk to each other. They don't know what each other's doing. And the way people hand out medications nowadays, there's a lot of them that do interact. And so in a lot of ways, it's hard to navigate. My parents are of Medicare age, and they're to the point where they need someone to help them with their health care. Well, I'm the CNO of the hospital, and I wanted to get her into an internal medicine doctor up here in Idaho Falls so that I could kind of get to know him and follow her health care. I was calling around doctors' offices, and because she was Medicare, nobody wanted to take her. Because hospitals can't refuse, but doctors can. And a lot of doctors don't want to take the Medicare reimbursements, and so they don't see it. Plus, a lot of them have limited their practices. They just don't want to see any more than they're doing. There is a shortage, believe it or not, in our area of primary care physicians. So I called about 3 or 4 offices and couldn't get her in. Then I pulled my trick I don't like to pull very often. I started calling and saying, "This is Kathleen, the CNO of IRMAC, and I'm trying to get my mother into the doctor." It didn't work. So I was talking to the administrator, to Doug, and was telling him a little bit about it. We had a medical staff meeting the next day. He announces it in the medical staff meeting that I can't even find a doctor for my mother. Fortunately, I had 2 doctors come up to me afterwards and offer to take care of her. But in helping her through that system, like she went and saw her doctor one time and he says, "We need a colonoscopy, but I don't do them, so you'll have to find somebody to do them." Well, an elderly person of 80 years old doesn't know how to work the system to find out which doctor does this, and if they do it, how do I make those arrangements? Because she did go to one doctor who set her up to have it at our friendly hospital across the street known as Mountain View, which we don't really have anything against, but you know, I work at IRMAC. I wanted her to have it at IRMAC. So she calls me up and says, I've got my colonoscopy finally, I'm going to Mountain View. And I go, Mom, you're not going to Irmac, or to Mountain View, you're going to Irmac. You call them back and tell them no. So she called them back and said, my daughter says, because she works, I need to have it at Irmac. And they go, okay, that's fine, but you'll have to arrange it. Well, if it hadn't been for me knowing how to call to get that set up, could she have done it? So it's very hard to navigate. The other thing that's really sad is we have poor outcomes. We have some of the poorest outcomes of all the industrialized nations. And we'll talk about that a little bit more. We talked a little bit about the uneven coverage and the uneven access. And the need is actually surpassing the capacity. You know, you have to take into consideration what's happening. You probably all heard about the different generations, hopefully. And I don't know, but you know, we had the traditionalists, and there were about 30 million of them. And when they went on to Medicare, I don't know if you're aware of this, but it takes 10 employed people for every one person on Medicare in order for them to have Medicare. Well, guess what's happening? The baby boomers are retiring. I happen to be a baby boomer. How many of us do you think there are? There's 88 million of us. The next generation down is Generation X. How many Generation Xers are there? Huh?
Like twice.
No, it's 27 million, less than half. So when you start doing the math, there's a lot of Generation Xers and Yers that have to support our, baby boomers, and there's not enough out there. So that's going to hurt the healthcare access. But more importantly, now you've got all these geriatrics, but who uses healthcare more than anybody? Geriatrics, but we haven't accommodated for them. We haven't even thought ahead. We've been going on what our trend has been, which is that traditionalist group, which is about 40 million and 30 million, and all of a sudden we've got 88 million baby boomers getting ready to retire, having health problems that need access to healthcare. So the need is truly surpassing the capacity. So how much are we spending? If you look at this, we spend more than per capita on healthcare than any other country. Back in 1960, our gross domestic product, we spent about between 5 and 6% of the gross domestic product was healthcare. The latest is right up around 18%. But to make it even more understanding for you, yeah, that's right. Back in 1960, that meant we spent an average of about $147 per person on healthcare. That's what it cost us to take care of each person in the United States. By 2009, that number had skyrocketed to $8,086. Now, interestingly enough, I just read some statistics the other day that said the average family of 4 is going to spend somewhere between $27,000 and $34,000 per year on healthcare if they're healthy. If they're healthy. That's their healthcare insurance premiums, that's just routine immunizations, follow-up checkups, a few things here and there that may be considered emergencies. How do you like the idea of you spending $24,000 to $30,000 of your income on healthcare needs? So, what do you think it is today? Let's have some guesses. Come on.
Yeah,
10,000. 10,000.
15.
15,000.
13.
13,000. 9,000. 9,000.
Is it
20. 20. Well, the young lady wins because it's a whopping 8,895. Why has it not increased that much? What happened in 2009? Yeah, we started really focusing on healthcare. The healthcare reform really became real. Obamacare started, Affordable Care Act came into place. Now we're not completely there. But it goes to show that when the government says, healthcare, you didn't take care of this yourself, meaning all of us administrators, so we're going to force it down your throats, it can happen. They can make it happen. Now, I don't know about you, but when I work, I like to think that I have a little say in what happens. I don't like to be told all the time what to do. And that's what I want to talk a little bit about. We, as new leaders, you have a great opportunity to help shape, because we know we have to have healthcare reform. We have to. If we don't, we're in trouble. So let's talk a little bit about, we still spend the most per capita on healthcare, so how are we doing? First of all, we have a shorter life expectancy by 4 years. Americans live 4 years shorter than any other industrialized nation. We have higher infant mortality, more auto accidents, and more homicides than any other country, industrialized country. We have higher adolescent pregnancy and STDs. Does everybody know what STDs are? Sexually transmitted diseases. We have the second highest of all nations with HIV positive people. We're number 1 in AIDS. We have surpassed Africa. That's pretty sad.
That's in total population.
In total population. Right. Well,
But still, that's
it's
not
still
good.
total population, you're right. But still, that's sad.
Yeah.
With the knowledge that we have in healthcare that we've done that.
Do you know what the number 1 highest HIV?
I do not.
Oh.
I do not. I'm sorry. I probably did when I researched it, but I don't recall what it is
I
now.
was just curious.
We have the most early deaths from alcohol and drug abuse. We have the highest number of diabetes, heart disease, obesity, and disability. And yet we spend the most money. So what does that tell you?
I wouldn't blame it completely on our healthcare industry. I blame it on maybe our lifestyles, maybe a little bit more than healthcare industry. But you're right, it does reflect what kind of care we provide, and so we need to do a little better.
Well, one of the things that healthcare reform is focusing on is you're going to be able to afford insurance based upon what some of your lifestyles are. You know, even at our institution, HCA, which is a large corporation, you know, it's not just Southeast Idaho; it's across the nation. We now give non-smokers a 30-something% discount on their health insurance, or maybe it's $34 less we pay a month. But there's a big difference. The other thing that's becoming a huge trend, and it's easy to say it in this group, is that most healthcare institutions will not hire smokers now. In fact, if you go for employment in most facilities, one of the tests they'll run is a nicotine test. And by the way, nicotine stays in your body for at least 90 days. So they won't hire you if you have nicotine, positive nicotine results.
I just applied for a job and they asked me that question.
So it's becoming, we're starting to get it. We're starting to understand why we need to pay attention to some of this stuff, but we've been too slow in doing it. Here's the one that just shocked me. The other thing is we talk about all these deaths from lifestyle, but in healthcare alone, we're responsible for somewhere between 44 and 98,000 patient deaths annually because of medical errors. Now that's equivalent to crashing 1 to 2 737s every single day. If that many 737s fell out of the air in the United States every day, do you think something would happen in a hurry? So why has it taken us so long in healthcare to figure it out?
Well, I guess it's kind of just what the Affordable Care Act tries to fix, where before we were kind of a volume-based system, and it's going to kind of a value-based system, where before the more patients you saw, the more money you made, but now it's kind of, you might get into this with the 3 factors that you have to meet for every patient that comes in.
Right.
So that's why, because they're trying to get through patients so quickly and not focusing on the quality and how the patient, their satisfaction is and everything like that, that they're just making small mistakes that could be avoided if they would have taken a little more time.
But isn't this alarming to you? Personally, if I read the statistic, I'd be a little afraid to go to, participate in the healthcare program in the United States. And I think that we're, I always count myself lucky because I am a nurse. I have a little bit of idea when we do have to have healthcare, what's happening. So the New England Journal, which I think is a great evidence-based journal, talks about that the gap between the care we intend to give and the care we actually get delivered is what the problem is. And that patients only receive about 55% of the care that they should have. And I think that's true, even working in the hospital I work in. So we've talked a lot about the underinsured and the uninsured. You look at what's happened here. And the impact on healthcare costs. It goes back to that. If someone comes in, and we do that, IRMAC's not really considered, we're a fairly good-sized hospital. We're certainly not the richest hospital. We're certainly not the most expensive hospital. But what would you propose that we write off in charity care every month? Okay, give me a dollar figure.
Oh, you mean actual amount?
Give me just throw out some ideas.
400,000?
400,000.
Higher or lower?
A little higher.
600.
600,000.
500,000.
500,000.
I'd say probably over a million.
Between $1 and $2 million every single month we write off in charity care. And we do all that we can to collect on that, helping the patient navigate the system to get on Medicaid or do the county indigent. But truly, we write off between $1 and $2 million every single month in charity care. So is it any wonder why other people's costs have to keep going up if charity care keeps going up? Until we fix it, somebody's got to pay the bills. So we talked about cost versus quality, and I talked about some of this. One of the things I want to talk here, though, that I thought was pretty interesting is in 61 studies in the United States, higher cost equates to higher quality in 34% of those 61 studies. So meaning if you're paying more, you're getting a better job. 30% of them stated that there's no correlation between cost and quality. And 36% of them found a negative correlation, meaning that the higher the price, the lower the quality. So it's all over the board. But it's kind of sad to think that that's really what's happening. To me, I like to use this analogy. If you could go out and buy a Ford Escort or a Lexus that are both going to cost you exactly the same price, which one are you going to buy?
Lexus.
Why?
It's a luxury brand.
It's a luxury brand. Why else?
Better quality for the cost.
Better quality for the cost. Doesn't really matter the cost, but it's better quality than the Ford Escort. I'm not picking on Fords, guys, so anybody get it? It's Ford people. Well, that's what the government's finally said that's true in healthcare. Why should we pay hospital Y the same thing we pay hospital X if hospital X is delivering higher quality and more patient satisfaction? And hospital X or Y is not. But normally we would have got the same reimbursement. So now they've gone to a thing much like what you're referring to, the value-based purchasing reimbursement, where there's a percentage of what they pay us that's held back. And we have a right to earn that back at the end of the year based on our quality scores, which are evidence-based measures, such as getting catheters out within 2 days after surgery, or that patients are given the right antibiotic just prior to surgery, or if they come in with pneumonia, there's a certain set of antibiotics that are considered the best to give to help them get well faster within a certain amount of time. Those are just some examples. Now, they claim if you don't do that, then you don't get the score, so you're not going to get back. Now, they're currently only holding out about 2.5% to 2.75% of what Medicare pays us. How much a year do you think that is? That's millions. So again, if we're not earning that back, that's hurting us financially. The fun thing that they've done that I think is really impressive is you can actually earn more than what they have paid you because they know not everybody's going to earn it back. So if your score is higher than what they say it is, if you meet the 100.7% because your scores were higher, you get 7% extra over what you earn 100% plus another additional 7%. So there's a real initiative for hospitals to meet these qualifications. Now, all hospitals are doing it, but it is true. And it kind of goes along with the Affordable Care and Obamacare and what we talk about. So cost does not always equate quality. But what we do know is in healthcare in today's society, we have to somehow leverage that out better. You should get what you're paying for. You'd be pretty disappointed if you paid the price of a Lexus for a Ford Escort, but you didn't get the quality. Vice versa, if you paid the price of a Ford Escort for a Lexus, you're going to be thrilled because you got a lot. And that's kind of what we have to start doing in healthcare. So one of the things that we really began to realize as hospitals is society is sending us a message. And the message is really clear. And that is that more people have growing expectations. People are more informed. I don't know how many of you do this. My husband and I, we drive down the road sometimes, and somebody will ask a question, what do you think this is? I don't know, Google it. And I'm immediately bringing my phone up and Googling it as he's driving. Do you guys do that? We have access to information at our fingertips that's unreal, that we've never had before. So people come in with more expectations. In fact, I would dare to tell you that about 60% of the people that ever come in my ER have already looked up their diagnosis that come into our ER. They may have real physical symptoms, but it's traced back to a psychosocial issue. I have never in my life, we're really fortunate, we have a behavioral health, which is a psychiatric type hospital associated with our hospital, which is part of our hospital. And so we have these on-call, what we call intake people who come to talk with patients to see if they qualify to be in the psych hospital. And they used to come over once or twice a week. Now we staff them 24/7 in our ER because we have that much business for them. And sometimes they have to call for help. So it's not always just that. I mean, their stress, believe it or not, causes a lot of diseases and a lot of health issues. Do you guys ever feel stressed? You're stressed because you have to be here and it's 5 o'clock and you want to be outside where the sun is. I don't blame you for that. But that's part of what we're dealing with. And so, we have to realize that what patients want is, when they talk about quality, even though the government measures quality differently, what they realize is patients measure quality based on how we made them feel. And that's completely different than what hospitals used to say how we measure quality. We used to say quality was we didn't have very many infections, we got patients better fast. That was qualityness. We followed evidence-based medicine. But if you were to go out on the streets and do a survey and talk to patients, they would say quality was how we made them feel. Whether we made them feel comfort, compassion, kindness, informed, those are the things that they rate quality on. And so that's one of the reasons the government said, okay, if that's what patients want, then we have to start putting that into our measurements, and that's where patient satisfaction comes in. And it is hard. It's really hard to get patient satisfaction. This is what also is interesting to me. We also have learned that the largest reason for bankruptcy in America is due to medical costs. 60-some% of the bankruptcies are all traced back to medical issues. That's not fair for people. So we've got to fix it. We also know what patients want is continuity, choice, and coordination. Kind of goes back to hard to navigate the system. Choice meaning they want to say in what happens. And continuity means they want to know that the care they're going to get is going to continue to care for them even when they leave the hospital. And you would be surprised how many patients, once they leave the hospital, get no care because they can't find it, or they can't afford their medications. So we may have got them in the hospital, we may have got them going on their medications, but then they get out and they pick up their meds, and they find out they can't afford them. I feel like I have a pretty good job. My husband works here at BYU, he has a good job. He's had a few health problems recently, and he has a prescription he needed me to pick up at Walgreens. We both have insurances, so we have double insurance coverage. And I call him up and I say, I don't think I'm going to make it home. They're doing CPR on me in the parking lot because I just picked up his meds. After insurances, it was like $800 and 4 months worth. And I thought, how does anybody else afford this? We both work. We both have good jobs. We have 2 insurances, and it was $800.
So is that just purely based on the price of the medicine, or do they do that to kind of compensate like they do in the
No, that's
hospitals?
purely based on the medication.
And is it just because the pharmaceutical or the company who makes it doesn't or has the patent on it still? And
Yeah,
it's not
exactly.
A generic?
It's a new med, so
Okay.
there's not a generic. Generics has been the best thing that's happened since sliced bread.
Oh yeah.
Because they force the prices of medications down. But there's no generic, so they can charge whatever they want. Now, my cost was $50 per pill for 30 pills. Why does a pill cost that much to me? There was really nothing magical in it. But you can see why a lot of people leave the hospital, and all of a sudden, they don't have, a lot of people couldn't have even paid that bill. They would have had to say, I can't afford that. And they would have turned around and walked away without the medication. I think there's a lot more of that than we even realize that goes on. And so that continuity and that coordination is very important to people nowadays. You probably already know this, but just a little history here. Medical reimbursement model in the United States used to be what we call fee-for-service. We did something, we charged it to the insurance company or the patient, we got reimbursed for it. And now what we're seeing is a completely different. We talked about the value-based purchasing. Not only do we only get so much money, and Medicare is big on that, they pay by DRG. Now I can't quote today's, and I went to our CFO to try to get the latest numbers. He wasn't available. So 10 years ago when I was at my previous hospital, for an example, for a patient who came in for a hip replacement, we got paid by Medicare $4,600. That was the flat rate. That's what you get. What was interesting 10 years ago was that hip replacement, that prosthesis cost $4,000. So how do you get a patient into the hospital, do surgery on them, get them well, and get them home with $600? You don't. You know, you have to try to, again, get to that juggling where you have enough patients that aren't Medicare that need a total debt, that you could charge much higher prices for, and you get reimbursed through their insurance. You know, but that's one of the things that has hurt the healthcare system is now Medicare comes in and says, I'm going to pay you X amount of dollars, and you get them well, or you don't get paid. And a lot of them, you know, I know a lot of elderly people get very frustrated because what they used to come in the hospital for and could stay till they felt well enough to go home, they come in the hospital for and they get hours. They may get a few days. And then they go home, and some of them don't have resources at home to help them. So they don't know how to take their meds, or they're not able to get up and move around, or do the things that they know they need to do to be able to get well. And then they get sick again. They might have a clot forming in their leg that moves to their lung, and it goes on and on and on. So can you see how fragmented our healthcare system is? We recently, and one of the things that makes